at the femoral head-neck junction. That abuts the acetabular rim during flexion and internal rotation. CAM lesions commonly arise de novo following trauma or as a result of healed slipped capital femoral epiphysis. This is an AP and lateral radiograph of the pelvis of a 33-year-old woman with mostly pincer type of femoral acetabular impingement of the left hip. And this is known as coxa profunda. There is an extreme surrounding of the head that it impinges. It leads to degenerative arthritis and what we call the coop, countercoop, meaning that they start forming osteophytes. Pincer type impingement results from acetabular overcoverage. عم بعيد اشياء لحتى يفوتوا براسكم وما تنسوهم, which verifies the acetabular rim as the source of bony abutment. Combined deformities may involve simultaneous pathology on both sides of the hip joint or possibly changes over time as a result of primary CAM or pincer lesion. What about the evaluation? The clinical evaluation of femoroacetabular impingement begins with a thorough history, during which patients are prompted to describe any activity-related pain centered in the groin, limits in passive range of motion of 105 degrees of flexion and internal or less with hip inflection are commonly noted. An anterior impingement test that places the hip inflection at and the activity-related pain symptoms. And here we have a typical description of the test we use to rule out. It's one of the tests, but you need a full evaluation of the patient. The hip is flexed to 90 degrees. The knee is flexed to a bit more than 90 degrees, and then abducted and internally rotated. This will promote impingement of the neck on the outer rim of the acetabulum, and the patient would say, ouch, that's my pain. Radiographic evaluation often demonstrates a classic CAM lesion at the neck junction in femoral-sided impingement. Correlation with both the history and the physical examination is important when evaluating CAM lesions because they have been noted in asymptomatic patients. Pincer impingement is associated with radiographic signs of anterior overcoverage, meaning you have by radiology a crossover sign where the rim impinges on the neck. There is a center edge angle of more than 40 degrees. This tells you that you have a deep acetabulum. You have an acetabulum down to nearly 0 degrees, and you have a positive crossover sign or a positive posterior wall sign. All these بدك تطلع عليهم، بدكم تطلعوا عليهم، بدكم تفحصوا، بدكم تشوفوا. بدكم تشوفوا is the anterior rim of the acetabulum is overlapping or bypassing the posterior rim. And as a result, this is more prominent in impinge. If you have a deep acetabulum where the LCE angle or the CE angle on the lateral view or the full profile view is 40 degrees, it tells you it's deep. On internal rotation or even external rotation, the rim of the acetabulum will impinge on the neck of the femur. This is the other side. بدي تخرق راسكم تفهموها. On the left hand side, as you're looking at this slide, you see that you have a pincer phenomenon. You see a gap between the obturator central portion and the ilioischial line. It tells you that everything is going in. So you would either have a profunda or a protrusio with impingement. While on the right-hand side, it shows you the count. I hope I'm clear. The crossover is present if these two lines, you see it at the lower right-hand side, connect, indicating acetabular retroversion that I have told you, spoke to you several times about it. The crossover sign has been implicated by femoral acetabular impingement and is thought to be disposing factor for osteoarthritis. This is the crossover sign. Please don't forget it. It tells you that the anterior portion of the acetabulum has crossed over the posterior portion. It tells you that the acetabulum is in retroversion. It tells you that you can have impingement and destruction of the labrum. It tells you that you can have a pincer result. Don't forget this. Coxa profunda, previously thought to be pathognomonic for pincer type of impingement, recently has been proven independent from other indices of acetabular overcoverage and should not be totally relied on. That's what I'm trying to say. You have to use a collection of findings. You have to see if you have a crossover the ilioischial line. You have to see how much is the acetabular index. You have to see how much is the CE angle on a false profile view. You have to see the whole thing, put them together, and then you'll arrive at a conclusion. So, speaking about some radiology from a radiology book, and I liked it. Coxa profunda floor of the fossa acetabuli touches the ilioischial line. Protrusio acetabuli is when the femoral head overlaps the ilioischial line and it goes medially. Yani, both profunda and protrusio are a deep acetabulum, but the protrusio is more severe than aspheric head when the epiphysis of the head protrudes laterally out of the circle around the head. This stands for the cam and the pistol grip and the double contour sign. Any irregularity in ossification with impingement can cause this. This is another view. I love this side where it tells you about the pincer finding, the pincer. Look at the head. Look at how it is impinging. MRI and magnetic resonance arthrography have been used as adjunctive tools in detecting labral and in the setting of femoral acetabulum impingement. The tests are costly and should be used with caution and only on a confirmatory basis, because the incidence of asymptomatic labral tears is that the patient has, but there are no symptoms. Recent data have shown that magnetic resonance arthrography only fair inter-observer reliability and a poor negative predictive value of 13 to 19%. What about the treatment? The treatment of femoroacetabular impingement encompasses spectrum of options that vary depending on the severity of the symptoms, the findings on imaging, and the patient demands and expectations. Non-surgical options, such as activity modification and anti-inflammatory medications, can be explored. After non-surgical measures have been exhausted or deemed ineffective, surgical measures should be considered. Arthroscopic procedures, including osteoplasty, labral debridement, and labral detachment with trimming and refixation into the bed. At times, you get so much destruction, you might excise the ligamentum teres and use it as a graft to replace the limbus. A study comparing labral debridement with refixation at 3.5 years demonstrated that both groups showed improvement based on subjective outcome measures. However, only 60% of the patients who underwent labral debridement had good to excellent results. 92% of the patients had good to excellent results. So if you clean the area, then reinsert the labrum, the result is very good. So arthroscopic labral refixation is influenced by two factors: the location of the labral pathology, amount and quality of the remaining labral tissue. Surgical procedures to treat femoroacetabular impingement have been used to address arthroscopic limitations of acetabular visualization. When I want to repair or debride the labrum, I do a dislocation of the hip. I can think, and I can see very clearly. I'm not an arthroscopist, but I found that it's giving me good results, not you. The structures with arthroscopic means is that you have to apply a large distraction force, and this has causes and numbness, and some even had some temporary paralysis. A direct anterior approach can be used to treat femoroacetabular impingement, and data support improved. Direct anterior approaches, however, offer only limited visualization of some acetabular lesions depending on their location. This is if you want to do an anterior approach without dislocation. Direct anterior approaches also may cause neuropraxic arthroscopic, and limited open approaches have been investigated and showed promising results in both Harris hip scores and the radiographic parameters at 2-year follow-up. Although further research is needed to determine the most effective surgical dislocation of the hip with an open osteoplasty and labral treatment as indicated. This option provides the best, I repeat, versatility, a wide variety of anatomic deformities, and in the proper hands often takes less time than arthroscopic treatment. We had recently admitted a female orthopedist subspecialized in arthroscopic procedures, mainly of the hip, shoulder, and ankle, and knee, of course. I recall an arthroscopic repair of the labrum. This orthopedic surgeon took 6 hours in the procedure and repeatedly had to apply traction on the hip to distract the hip to be able to see the labrum. Midterm results of surgical hip dislocation indicate that 82% of patients are satisfied or very satisfied with their results, and 83% of patients rate their hip function as near normal or normal. This study also indicates that 3% of patients undergoing a surgical dislocation underwent a total hip arthroplasty during the follow-up period, and that the predictors of a poor outcome were older age, female sex, low body mass index, and residual full thickness cartilage defects. Surgical dislocation also provides an opportunity to reconstruct a labrum using the ligamentum teres in cases for which remaining tissue is deficient. Demonstrates subjective improvement at 2-year follow-up in 75% of patients. Moreover, surgical dislocation has been shown in multi-center study to be a safe procedure with a low complication rate. In 334 cases, the procedure did not result in femoral head osteonecrosis or femoral neck fracture. This terminates our knowledge about femoral acetabular impingement. I want to ask at this stage what or whether you have any questions. Any questions? Khalid. Yeah, Khalid.
There is one question, Dr. Abdelragib.
يلا خليهم يسألوني، خليهم يفحصوني.
Dr. Jone, مرحبا.
يلا.
Is there any age limitation for osteoblasty and this open dislocation of the hip for treatment of femoral acetabular impingement?
Well, look it, I'll tell you, in cases where you have evaluated your patient well, and you have definitely an impingement, but without significant findings, there is no limitation in my mind of performing a careful dislocation of the hip and seeing better. But you have to be very careful. all the posterior capsular structures should be intact. Don't apply too much traction on this area. You can divide the ligamentum teres and use it as a graft. I looked into the literature and I found that in authorities who do a complete dislocation, they have not had a single case of osteonecrosis. I know one French orthopedic surgeon named Kovalchuk. He came and gave us a talk in Lebanon, and he used to do a dislocation and repair these, and he claimed that he never had osteonecrosis. So in my mind, I don't think there's any limitation for the cases where it's indicated. If you have a far advanced case, it's not what I cannot see what the purpose of doing any surgery on this patient and going directly to doing an arthroplasty procedure. Okay. Are there any other questions? Did I answer you? Sure, ya Khalid.
Dr. Jone, thank you.
لا خليني, why did he ask that question?
Yeah,
We want to know.
yes. If I find that after osteoplasty, 1 year and less, I did Smith-Patterson anterior approach, and later on he need an the patient need an arthroplasty. Do you think I have to go the same approach, or the approach I am experienced with it? I have experience with it.
I'll tell you something. You should choose your case well. Patients where you have considerable changes. We have found that wherever there is cartilage lamination, cartilage destruction, the results are not good. The results are not good. They end up needing a total hip. But in patients where you have highly findings that it's only at the beginning, the result is good. And what I would tell you, please, from my experience, observed, if you want to do some work on the rim of the acetabulum, always consider dislocating the hip. But do the approach that is indicated in the literature. Do the anterior approach away from the vessels. And do it very gently. Okay? Thank you.
Well,
Am I clear? Sure.
Dr. Jone, there is a question. In cases of femoral sublunar impingement, what is the percentage who will develop osteoarthritis?
Again, I repeat.
The percentage.
I'll tell you something, Khalid. Femoral acetabular impingement can be from one simple form to a very severe case. Yani, if you have a fracture, and this has been going on for some time, I'll tell you it's 100%. If you have a tethering and you have lamination of the cartilage, then I'll tell you for sure the patient with time will end up with a total hip. But the timing process is different. Okay?
Okay.
Now this procedure, all these procedures were created to delay osteoarthritis.
Yeah.
This is what we mean. Okay?
Okay.
Type. Now I'm going to carry on with developmental dysplasia of the hip in the adult. What should we know about developmental dysplasia of the hip? First of all, you should know that it is exact issue that we were speaking about. And we have an acetabula under coverage. The contact forces on the hip are very different. When you have a dysplastic hip, the load on the hip is very different than a normal hip. You have a smaller surface area, and as a result, you're bound to have degeneration, and you're bound to have labral pathology. And all these lead to early osteoarthritis. Now, you should know the measurements that we use. You should know how to measure the tonus angle. Know that you can see the ilioischial line if you want to draw it now. If you look at the head is laterally displaced. The acetabulum is insufficient. You should know about the CE angle, the tonus angle, the acetabula angle. You should know where the sourcil is. And you should know about the teardrop sign. So you should know how to obturate the arc if it's disturbed. These will all tell you about DDH. Now, you should know of how you take a full profile view. This is a full profile view. And when you do a CE angle, the CE angle, if it's less than 20, it will tell you that the patient has a dysplastic hip. It will tell you that the hip is subluxed. And it will tell you that there is more force on the head, and this with time will lead to degenerative arthritis. You have to know how to draw Perkins line. You have to know how to draw a line from the outer margin of the acetabulum to the center of the head. The junction of these two lines gives you the angle. It gives you the CE angle. And this should be more than 20 degrees. Otherwise, you'll have a dysplastic hip. Okay? And instability. So this gives you the tonus angle, which is a horizontal line, vs a line tangent to the upper margin of the acetabulum gives you the tonus angle. We have a patient less than 35 years old who has a round femoral head. He has tonus 0 to 1 arthritis, which I will be discussing very soon. You have to take maximum abduction radiographs. You should see whether the head is covered by this position and whether there is a normal joint space. Then you can do surgery on these patients. And this will bring us to periacetabular osteotomies. Gans, a brilliant fellow, he made the Viennese periacetabular osteotomy for the purpose of improving acetabular coverage. He improved the abduction of the hip. He improved medialization of the hip center and retroversion of the socket because it is normally anteverted. And he kept the posterior column intact. And the advantage of this procedure is that the woman can continue to have a normal childbirth. In this steel technique, you change in the pelvis wall, and therefore we have to deliver the C-section. But you should choose your patient well. We all know that in DDH, with the high riding hips, we know that the acetabulum is anteverted. We know that the femoral head is anteverted. At times it reaches 90 degrees. The normal is 10 to 15 degrees. We know that they could have a small acetabulum, which is below, while the pseudoacetabulum is above. We know that it's at times difficult to find the true acetabulum, but we need to find it. We need to identify a true hip center. We know that the greater trochanter is posterior, and for this reason, when we are operating, we like to correct the amount of anteversion. The trochanter becomes lateral. Before, it was posterior. The function of the abductors was not normal. When you bring it lateral, they would function much better and more efficiently. You have to know when you're dealing with these patients. Let me tell you about these patients. That is much more important than performing the surgery or choosing the hip. You have to see what you have to do beforehand. You have to see whether you have to do any shortening or derotation. You have to see your cup, whether it will fit in or whether you need an allograft or an autograft. In these cases, you can use the head as an autograft to deepen the acetabulum. So, I'm telling you, young surgeons, with DDH, you need small parts. You may need to bone graft the acetabulum. And it is best to place the socket in the true acetabulum. We know that biomechanically it's more effective. You need to correct the version issues in the femur. And you may need femoral shortening, osteotomy. You have to preserve the abductors. And by preserving the abductors, you're changing position of the trochanter from being posterior to lateral. And throughout, you should protect the sciatic nerve. If you're doing shortening in an indirect way, you're doing lengthening. The shortening is done to bring down the head to the true acetabulum. But when you reduce it, you gain length. You should not gain more than 2.5 to 3 centimeters. Otherwise, you can get a sciatic nerve palsy. If you do get a sciatic nerve palsy, you should flex the hip and knee and put the patient for some time, give him anti-inflammatory steroids, and hope for the best. Now, if you have a DDH and the patient is being treated conservatively to reach a certain age, at times the pain will become so severe, even though you ask the patient to lose weight, you ask him to limit his activity, you ask him to take anti-inflammatory medications, you give him intra-articular steroids, but when I give intra-articular steroids in the hip, I worry. I worry for infection, and this will prevent us from doing the necessary surgery on this patient. I avoid giving steroids intra-articularly in the hip. I agree that in the knee, it gives us a limited but a good result. Now, if they don't improve, you have no choice but to do a total hip arthroplasty after giving the patient 3 to 6 months time. Now, when you're doing a total hip, please, I have this drawing in several forms in this lecture to pay attention as you're inserting the cup. First of all, the cup is flat, the acetabulum, and you need to ream. So you're coming close to the important structures within the pelvis. You have to know this drawing by heart. Please look at it. The places in green, you can put screws, but you have to put it in a safe way. Don't put them too long. Okay. Anterior screws, never. Inferior screws, yes, but with care. But you have to be careful for the obturator nerve. In the posterior screws, don't put them too long. The average I've noticed is 3 centimeters that I put, but you have to measure and see. Beware of the sciatic nerve. Be aware of the inferior gluteal nerve and vessels. And in the superior portion, you have the superior gluteal nerve, the gluteal vessels, and the sciatic nerve. So please, this is a drawing we like to ask. This is a drawing that we always ask whenever we give you a hip in the exam. Remember the areas where you can put screws and where you cannot. Remember what you can injure if you put a screw in a certain quadrant. So please study this well. We use surgical approaches on the hip, and we follow this manner. We use an anterior, we can use a lateral, and the posterior approach. The direct anterior approach needs a learning curve. I had to practice this for over 1 year when I was young like you. And then I began to use it more often. What I had is that I had a tight mean of rasping the shaft. At times I had a fracture. So you have to be careful and you have to have a learning mind to do the anterior approach. But people who do it claim that the patient recovers quicker. And they claim that dislocation is much less in this procedure. I have observed this. And I would like to add to it on comparing direct anterior approaches with posterior approaches. I found that the infection rate was less whenever I used the anterior approach. Now, we go through an interval between the sartorius and the tensofacial lata, but you have to be careful for the femoral nerve, please, and the superior gluteal nerve. In addition, in this approach, many times we see the lateral femoral cutaneous nerve lying in front of us. Be careful, don't cut it. It's irritating to the patient when he tells you that they have numbness on the lateral aspect of one side. Okay? Now, the femoral nerve limits distal extension. And this is becoming very popular, this approach. This is the posterior approach. You're going between the gluteus maximus and the gluteus medius. Be careful from the nerve supplies of these muscles. Be careful of the sciatic nerve and the medial-femoral circumflex artery, which lies beneath the gluteus maximus. The dislocation rates are higher than other approaches. But I use this approach quite a lot because I find that I can control rasping the shaft, and I see the acetabulum quite well. I don't have problems in these cases, but I aim at doing a proper soft tissue repair, and approach I use when I use larger femoral heads, and the dislocation is much less. Nowadays, we're using the double mobility cups, and these are giving us a very low dislocation. The Watson-Jones procedure approach, the interval is between the tensofacial lata and gluteus medius. Again, there is femoral nerve superior and lateral femoral circumflex artery injuries. Okay, we used to use this a lot in the past. Nowadays, we don't use it much. And then you have the direct lateral approach, which you slit the gluteus medius, the vastus lateralis, and then you remove everything forward and you come into the hip. Developmental dysplasia of the hip results from acetabular undercoverage of the femoral head during osseous maturation. The decreased joint conformity leads to elevated contact forces over a smaller surface area. Abnormal motion, femoral head relative to the acetabulum may also induce labral pathology. For example, abnormal joint kinematics and related sequelae contribute to early onset of osteoarthritis. Now, just one second. DDH has been classified according to the severity of hip subluxation relative to the overall pelvic height and more qualitatively as a dysplastic hip, low dislocation or high dislocation, depending on the location of the functional pelvic articulation. You have to know these two classifications. The Kraus classification, which I will not go through in detail, you have to memorize it by heart, and you have to know the Harto-Philakidis classification, which is easier depending on the level. If the hip is subluxed, not completely, it's type A. If it's dislocated but just above the acetabulum, it's type B. And if it's high, I find it much easier than the Kraus. Kraus is a matter of percentage, how much the head is dislocated and how high it is the acetabulum. Patients with DDH often describe a history of growing pain that increases with activity. They also may note mechanical symptoms that may be related to concurrent labral pathology. In contrast to patients with femoral acetabular impingement, patients with DDH are not classically limited in passive range of motion. They can probably even move the hips much more, but may demonstrate a positive impingement sign if labral damage has occurred or there is an anterior apprehension sign. In patients with advanced disease, abductor dysfunction and trilimbar gait may be observed. And the reason for this is, first of all, they are ineffective because they don't have the proper length. And second of all, they have a abnormal function due to their insertion being on the greater trochanter and is posteriorly located. Keep this in mind, please. The radiographic evaluation of patients with DDH will demonstrate a lateralized femoral head and acetabular undercoverage. There is also increased anteversion of both acetabulum and the femur. I spoke to you about this previously. Now, these views, you should know them. I've already told you about them. The CE angle on the lateral view in patients with DDH is usually less than 25 degrees. And the acetabular index is more than 10 degrees. Keep this in mind. A break in Schenter's line or the cervical obturator line that is larger than 5 millimeters also indicates DDH and is associated with excellent intra and inter-observer reliability with a sensitivity and a specificity of 83% and 98% respectively. Femoral head sphericity is also important to note on radiographs because this plays a role in the treatment algorithm for DDH. This table tells us a lot. I got it from a radiology book. It tells you about the degree, the lateral center edge angle. تعملها على الفوق profile. If it's more than 25 degrees, it's not. 20 to 25, it's borderline. Less than 20, hip dysplasia. Acetabula index, meaning that it tells you about how deep or how flat the acetabulum is. If it's more than 10 degrees, it tells you it's flat. Extrusion index greater than 25%, of course, is hip dysplasia. False profile view, anterior edge angle greater than 25, less than 20 degrees, between 20 and 25 tells you whether it's borderline or dysplastic. MRI is a valuable adjunctive imaging modality in DDH because it can help define any labral pathology and assess the articular cartilage condition. T2 mapping of the articular surface can detect cartilage disruption and delamination. Delayed gadolinium enhanced MRI of cartilage is useful in the earlier stages of cartilage degeneration because it can detect changes in charge density within the articular cartilage and correspond to changes in proteoglycan content. Appreciation of the cartilage in patients with DDH is paramount when deciding on predicting the success of non-arthroplasty treatment options. Treatment of DDH in skeletally mature patients depends on the patient's age, pain activity level, and expectations. The sphericity of the femoral head and the condition of the articular cartilage, as I mentioned, also can dictate available options. Out of round femoral heads and full thickness cartilage defects. This applies to femoral acetabular impingement and a poor outcome with non-arthroplasty treatment modalities. Patients younger than 35 years with round femoral heads and intact articular cartilage demonstrated on MRI or plain radiographs, namely TONUS 0 and 1, are the best candidates for non-arthroplasty treatment in the form of Viennese periacetabular osteotomy, or PAO. This is a patient who has a normal hip. The center edge angled should be 20 degrees or more. If it's dysplastic, it's less than 20 degrees. This is the angle that we have between the both arrows. It's normal if it's 25 to 40 degrees. And greater than 40 degrees, indicative of femoral acetabular impingement, as we just spoke about. This is the lateral CE angle. This is the tonus angle. Okay, the tonus angle. Before surgical intervention, radiograph obtained in maximum abduction should demonstrate restoration of the acetabular coverage. Don't forget preservation of the joint space. We mentioned this. You have to work up your patient carefully. You have to do a good, proper preoperative planning to do any form of surgery on these patients. The BNS periacetabular osteotomies are contraindicated in patients who are younger than 11 years. Let me be honest. We had a patient who had a dysplasia, and we asked one of the residents who was being examined for the board, what would you do? And he mentioned periacetabular osteotomy. He flunked, because you should know that patients younger than 11, there would be a gross disturbance, and we should not do it. This is how we do it. We leave the posterior column intact. It gives us a better operation, and the patient can walk earlier in this patient. Okay? And this is how we rotate the acetabulum more, putting it more in a horizontal position and correct the acetabular anteversion. We put it in a retroverted position. This is how we do our osteotomy, and this is how we bring it forward. The BNS periacetabular osteotomy, originally described in 1988, represents a powerful tool in pelvic correction because it is positioned close to the joint. It is positioned in a position close to the joint. At first, we used to do various osteotomies. The distance, the lever is far away. The primary corrections associated with this procedure include improvement of acetabular coverage via abduction, medialization of the hip center, and retroversion of the hip socket via extension. So this way, it will maintain the hip in a more stable position and give it better coverage. The osteotomy is relatively stable and requires minimal instrumentation because the posterior column is intact, as I mentioned repeatedly. Pelvic dimensions remain largely unaltered, preserving the option for vaginal childbirth. BNS periacetabular osteotomies have been shown to restore hip biomechanics by increasing the load-bearing surface of the joint to within a normal range. And in general, most patients demonstrate improved outcome measures. In patients with tonus grades 0 and 1 changes, the long-term results reveal a survivorship of 75% at 20 years. Patients with more severe arthrosis, however, demonstrate a 13% survivorship at 20 years. Many patients with DDH will require a hip arthroplasty. Arthroplasty in the setting of DDH involves a special set of technical considerations related to the acetabular and femoral deformities observed in DDH. Alternative bearing surfaces should be considered secondary to younger patient age, often encountered among patients with DDH and need an arthroplasty. Acetabular deformity with DDH leads to bone stock deficiencies, especially anterior superiorly and superolaterally. In cases of high hip dislocation, the true acetabulum can be difficult to identify and prepare. It is preferable to place the acetabular component in an anatomic position. Previous work has demonstrated an unacceptable high rate of loosening whenever the acetabulum is placed high. Measures to augment acetabular component coverage using autograft from the resected femoral head, thereby avoiding superior component placement or component medialization, and demonstrated graft survival at 11 years. Femoral deformity in the form of excessive anteversion, number one, coxavalgia, metaphyseal, diaphyseal mismatch often are encountered during total hip arthroplasty in patients with DDH. It is for this reason you have to have a proper planning. Appropriate preoperative assessment can help plan for these occurrences and stem modularity. At times we use the SROM. Why do we use the SROM? Because we can correct the anteversion directly in the region of the connection that is present between the stem and the metaphyseal component. In addition, femoral length may need to be adjusted in cases of high dislocation or Crow type 4 dysplasia to avoid injury to the sciatic nerve. I repeat, you should not lengthen the extremity more than 2.5 to 3 centimeters. Be very careful. And when a femoral length of 3 to 4 centimeters is expected, subtrochanteric osteotomy can be performed at the time of total hip arthroplasty, and excellent results at 5-year follow-up can be expected. This is showing you of how you have a high riding hip, a Crow, I would say 2 to 3, and of how the hip is brought down to the true hip center. And a osteotomy was done, a porous coated stem was applied, and showing you of how this is being done. Okay, finished for DDH. Any questions? Any questions? شو يا خالد؟ Khalid. So I'm going to take a break of 5 minutes and then I'll carry on. في شيء أسئلة؟
بعدين يعني واحنا بنحضر
أنا رح برتاح لي شي 5 دقايق. Traumatic arthropathy. failed open reduction and internal fixation of femoral neck intertrochanteric and acetabular fractures often necessitates reconstruction and salvage surgery that involves arthroplasty. This is especially true in patients older than 45 years and those with underlying inflammatory arthritis, and in settings involving acetabular cartilage loss or derangements. These patients require special technical considerations secondary to their acquired iatrogenic deformity, the presence of hardware, and suboptimal bone quality. Patients who have failed open reduction and fixation of the intracap femur or the acetabulum should undergo a workup for an infectious etiology of their non-union in the form of a physical examination, laboratory testing that includes complete blood count, CBC with differential, erythrocyte sedimentation rate, and C-reactive protein levels. Patients may undergo additional testing, including an ultrasound or fluoroscopic guided hip aspiration, and this I will be discussing at the end of this lecture. And aspiration samples must be sent for a CBC with differential, as well as gram stain, which is not very reliable, and cultures if you're lucky to get them positive. Tissue should be obtained at the time of surgical intervention and sent for pathology and culture. If pathology reveals acute inflammation, reconstructive arthroplasty should be aborted and staged with hardware removal, antibiotic spacer placement, and intravenous antibiotic therapy. This is very important to cover. When you get a patient who has a failed, let's say, hip nailing or whatever it may be, and the patient is coming to you for an arthroplasty, you should work up that patient carefully to make sure that he doesn't have an infection. And when you're removing the material, you should remove tissue for counting the white blood, the neutrophils. If they're more than 5, then you should wonder, is this an infection? You should try and culture the tissue in these patients that have been operated before and ended up with a failure. Nutritional and metabolic workup should be initiated to help direct future attempts at salvage. Nutritional deficiencies can influence wound healing over prosthesis and may play a role in impaired osseous ingrowth into uncemented components. Once identified, metabolic disorders can be appropriately addressed, which may decrease the risk of periprosthetic infections or periprosthetic fractures. Radiographic evaluation is critical in planning the reconstruction of a failed internal fixation about the hip. Broken hardware. بدي يكون عندكم كل الاكويبمنت يلي فيكم تشيلوا broken hardware فيه. Because this may complicate the procedure. After the hardware is removed, stress rises are created and should be appropriately bypassed by new components. You should use longer stems that they will go to that the thickness below the level of the last area of the screw or stress riser. The relationship between the extent of the hardware removed and the length of the selected prosthesis must be fully elucidated before doing the surgery. Abnormalities in femoral version, offset, and bone loss also should be appreciated, as these may dictate approach and implant selection. Non-united acetabular fractures may not be able to support a socket component without revision fixation or the use of a cup cage, which necessitates appropriate instrumentation and planning. Femoral neck fracture, non-unions, may be addressed with a hemiarthroplasty or a total hip. Most cases should be treated with the total hip, secondary to reliability of pain relief. If a patient is experiencing cognitive decline or is inactive with intact acetabular cartilage, hemiarthroplasty may be an appropriate option. At surgery, the acetabulum should be critically assessed because hardware cut out can damage the articular surface and mandate a total hip arthroplasty. Disuse osteopenia is very important as you're preparing the acetabulum. You should take care to avoid overreaming because the acetabulum might just slip into the pelvis and then your problems will solve. If soft bone is discovered, screw augmentation of cup fixation should be performed. Total hip arthroplasty in the setting of femoral neck non-union is associated with a higher rate of dislocation and superficial infections than primary total hip in the setting of a femoral neck fracture. One of the questions I like asking, which patient would end up having a dislocation more? A patient who has had a fracture, you've done a total hip, or a patient who has degenerative arthritis, and you have done a total hip, both using the posterior approach? The answer, the more the fracture is associated with more dislocation because the patient is not used to not moving his extremity. He will be moving his extremity before he was totally normal. One long-term study employing only hip arthroplasty components in the treatment of femoral neck non-unions, 93% and 76% survivorship at 10 and 20 years respectively. 4.5% of the patients had recurrent dislocation. The use of uncemented components, larger head sizes, lip liners, dual mobility bearing surfaces may lead to improved results in this population. Lip arthroplasty in the setting of intertrochanteric non-union can be technically challenging secondary to malunited trochanter, preventing entry into the intramedullary canal. Shaping the bone with a high-speed burr can facilitate a path for reamers and the final component without completely compromising the trochanter or necessitating a trochanteric advancement. Femoral geometry is very important. Alterations to version also may necessitate either a cemented implant that can be used to sheet the given anatomy, using a smaller component and rotating it within a cement mantle, to a desired version or modular stem that can allow version variability. Calcar replacement stems may be required at the calcar level to address bone loss. Normally, the metaphyseal bone has been violated to an extent which precludes the placement of a standard prosthesis. Longer stems should be used to bypass stress rises created by previous hardware by at least 2 cortical diameters. Total hip arthroplasty performed after failed fixation also has provided reliable functional improvement and pain relief. Surgeons must be prepared to deal with broken hardware, bony defects, heterotopic bone in these challenging reconstructions. In series of 33 patients, one study noted pain at final follow-up between of uncemented components. 3 patients in this study required a revision of their cup secondary to osteolysis. 2 stayed and 1 loose, whereas in other patients, cup was revived loosening and instability. Note, these data were collected before the introduction of highly cross-linked polyethylene. So we're coming more to the highly. Now we come to osteonecrosis. Any questions? If there's no questions يعني كلكم فاهمين كل شيء.
لا بصراحة الشباب مركزين.
شو؟
محاضرة واضحة. أي سؤال يا شباب؟
Very clear. Inshallah. Now we're coming to osteonecrosis.
Okay.
This is an interesting part. If you look over here, you see a classification group. What classification is this? شو يا جماعة? What classification do I have on my slide? شو اسمه؟ شو اسمه؟ ما عم بسمع.
الترجم قالوا في كات.
في كات. مظبوط. في كات classification. Very good. There is another classification. شو اسمه؟ What is the other classification for osteonecrosis called? يا شباب لازم تقروا. لازم تقروا، لازم تعرفوا هالأسئلة رأسا، لازم تقروا على التوبكس قبل. قلت لكم إنه عم بعطيكم these and hip reconstruction.
Yeah,
If
the
you
another
don't read, you won't pass. It's called the Steinberg.
yeah, Steinberg, yeah, Beatles. Like Steinberg. Yeah.
يا جماعة بليز اقروا، قروا بتفهموا أكثر، قروا بتحفظوا أكثر، قروا بتعملوا أحلى بالفحص. Osteonecrosis or avascular necrosis of the hip means death of a segment of bone in the femoral head due to interruption of blood supply. The etiology of this condition is not fully understood. There are several risk factors associated with osteonecrosis of the hip. This vascular insult to the femoral head can lead to collapse of the articular surface, an asymmetric femoral head, and as a late result, coxarthrosis. In patients younger than 50 years who are undergoing total hip arthroplasty. Osteonecrosis indication occurring in 29% of patients having a total hip. The underlying cause of vascular compromise can involve multiple condition factors, most notably trauma, steroid use, alcohol use, sickle cell disease, AIDS, and idiopathic causes. A genetic predisposition to osteonecrosis has also been postulated. What is the difference? If you look at the intra-articular etiology, can be fractures, labral tears, seronegative arthropathies, rheumatoid arthritis, systemic lupus, erythematosus, infections, avascular necrosis, childhood disorders such as and slipped capital femoral epiphysis, femoral acetabular impingement, degenerative osteoarthritis, and metabolic conditions, which are well known and listed over here. And not forgetting neurologic conditions. Extra-articular conditions you can think of adductor tendinitis, iliopsoas, piriformis, and tensiofacial lata. And the pain can come from the spine and pelvis. You have to know the list. And the visceral situations. Always try to rule out a hernia, testicular pathology, urolithiasis, intrapelvic pathology, and intravaginal pathology. Vascular. If you find a patient who has pistol-shot pulse in the lower extremities, dissecting aneurysm, beware of an aneurysm. Beware of arterial insufficiency. Try and differentiate between vascular disease and neurogenic problems. Be very careful to evaluate your patients well. Osteonecrosis is caused by this list that has been associated with osteonecrosis. We speak a lot about the crescent sign. Why? Because this is the limit where we can do conservative treatment, DS arthroplasty. You can demonstrate it well by means of an MRI. Crescent sign is a radiolucent line underneath the infarcted portion of it. This portion cannot remodel. It's weaker on forces being applied over there. It cannot react to changes of forces, fracture and collapse. And this is the third stage in the RSCAT classification and in the Steinberg cluster time where you need to do a total hip. The age and underlying diagnosis of the patient is important while considering the treatment. The extent and location, weight-bearing surface, combined necrotic angle, greater than 30% is a poor indicator. The presence of femoral head collapse. If it's less than 2 millimeters, VS more than 2 millimeters. The worst prognosis can collapse. Pre-collapse, the treatment is different than the post-collapse. In the pre, you can do a core decompression and bone grafting. Some do a vascularized bone graft. Some do an osteotomy and shift the weight-bearing area. In post-collapse, nothing is left much. The most important is to do a total hip. One should not forget down to the region of the trochanteric region. And this is self-limiting. I have seen quite a few of these cases occurring following delivery. Between the 5th and 6th decades. Now, it's an intraosseous microcirculation coagulation. They have generalized venous thrombosis and they have arterial occlusion. So you have intravascular coagulation is always triggered and activated by some underlying etiological risk factor. We know that the risk factors are antiphospholipid antibody syndrome, hyperlipidemia disorders, and hypersensitivity conditions. Also, some condemn viral and protease inhibitors. These are the hypercoagulable states that are associated. They can have a protein S and protein C deficiency as occurs in Legg-Calvé-Percy's disease. Osteonecrosis of the femoral head has been classified according to multiple systems. The Arlett-Ficat classification uses a qualitative assessment of radiographs, whereas the Steinberg system combines radiographic and MRI findings in an attempt to quantify the percentage of head involvement. There is an international classification system which combines size and location of the lesion in relation to weight-bearing area of the femoral head. This is the Arlet-Ficat that I showed you at the beginning of this section. And you have the Steinberg classification, where you can have stage 0, where you have a normal or non-diagnostic radiograph, bone scan, and MRI. In 1A, you have a normal radiograph and abnormal bone scan and or MRI. 2A is an abnormal radiograph showing cystic and sclerotic changes in the femoral head. And 3A is the limit, subchondral collapse, producing a crescent sign, flattening of the femoral head in 4A, and joint narrowing with or without acetabular involvement. And finally, 6, you have advanced degenerative changes. So the stage 1 is the earliest clinical manifestation of the syndrome, which is pain in almost 50% of patients. They have a limited movement of the hip joint in all directions on physical examination. They have radiographs which are normal or at most show only minor changes, such as subtle loss of clarity with poor definition or blurring of the trabecular pattern, patchy osteoporosis in comparison with the opposite side, but the changes are not really significant. Stage 2 extends over several months or even much longer. Clinical signs persist or worsen. Radiographs show changes in the trabecular pattern of the femoral head. They have sclerosis. They have zones of lucency, and you can have zones of mixed forms. Stage 3 is pathognomonic imaging features. They have the crescent line due to subchondral fracture. Out of round appearance, segmental flattening of the femoral head, paradoxically, and because of the limited size of the sequestrum, the joint space is preserved or even increased. Stage 4, they have a terminal phase of necrotic process. Hip movement is progressively diminished until only a small range of flexion remains. The radiographic picture is of osteoarthritis superimposed on a deformed femoral head, which is characterized by progressive loss of articular cartilage and the development of acetabular osteophytes. So don't forget the Steinberg classification. We ask it, and you have to know in detail about the Steinberg classification. Okay. Also, the volume is important in Steinberg. A is a mild less than 15% involvement of the head, B 15 to 30, and C is severe over 30%. The size of the necrotic lesion most strongly influences the risk of head collapse. Hypercoagulable states, don't forget them, you have to know them, and know the parts of the Steinberg classification, and know the crescent sign. This is in the slide above the X-ray. It shows you a typical, and the larger it is, the more collapse you'll have, and you'll end up with degeneration. Prior to this, you can do non-arthroplasty techniques, but once this occurs, you have no choice. What about the evaluation? It can be difficult to identify secondary to lack of Don't forget that all patients with problems can have radiation from the groin to the knee. Every patient coming to you with a limp and the knee pain, you should take an X-ray of the hip to avoid missing it. AP views of the pelvis should be taken and analyzed, and MRI could be indicated to confirm the diagnosis. You see that there's an increased density and there's depression of the avascular zone, as is shown in the slide on the right-hand side. This shows it further. Imaging studies are important to elucidate and determine osteonecrosis prognosis. Previous work has demonstrated that lesions comprising less than 15% of the femoral head will remain relatively quiescent, and is in the setting of FICAT stage 1 or 2 will only necessitate total hip arthroplasty in less than 10%. So the size of the lesion is important. If it's less than 15%, only 10% of these patients will need a total hip. MRI measurement of the involved portion of the femoral head also has been validated as a predictor of future collapse. Arc angles measuring the necrotic head segment visualized on 2 radiographic views have demonstrated prognostic value for determining outcome after exercising non-arthroplasty treatment options. This is an MRI showing you a zone necrosis. Let me tell you, ipsilateral involvement is quite common. Know that ipsilateral hip has signs, but no clinical evaluation, no clinical finding, because many of them end up having a total hip. They will develop, they will progress further. And in these cases, it's better to do a core decompression in these patients. Okay, so the contralateral hip, even if affected, often is asymptomatic on discovery. A 2010 study demonstrated that most of these asymptomatic lesions will progress to collapse if left untreated. So you have to do a cord decompression. This is a patient who was late. He had a depression of his chest, sign of his necrotic component, who ended up having a total hip arthroplasty. Now, what are the treatment options? Cord decompression. You can put a fibula strut. It can be vascular or not. You can do an osteotomy to change the zone of weight bearing. And you can finally do a don't forget that bone does not expand. And if you have one of these conditions that has caused the intravasculation, it is not like in soft tissue where it expands. So bone keeps the pressure on it. So you have to treat it in a special way. And that's where cord decompression comes in. So with avascular necrosis, you have bone is gets disturbed and collapse. Okay, so don't forget about this. And I'm going to mention pre-collapse treatment options include non-surgical modalities, cord decompression with bone marrow grafting, vascularized bone grafting and osteotomy. Give your patients biphosphonates, keep them off weight bearing. Some have, this has been investigated. However, results have not proven to be effective. These modalities should be reserved for patients who are otherwise poor surgical candidates because they are less successful than surgical methods. Core decompression has been demonstrated as an improvement over non-surgical treatment with a success rate of 84% in patients with FICAT1 disease and 65% in those with FICAT2. And you can add to it autologous bone marrow transplantation, which has become a common adjunct to core decompression. Because of necrosis often affects the anterior superior portion of the femoral head, rotational osteotomies have been used. But I'll tell you of one osteotomy which was a fiasco, which is the rotational osteotomy of Sogioko. And this has caused harm to the patient. You can do a valgus or varus by taking certain x-rays with the patient either in full flexion or extension or adduction or abduction and see if the zone of necrosis moves. And then you can do your osteotomy accordingly. Don't forget about using a free vascularized graft, which is popular in one of the centers in the United States. So, Ford stated that creating a wound in bone stimulates neogenesis healing. How? You decompress by making a drill, removing the bone, and this will decompress it. And they claimed that the whole core heals by adjacent creep subchondral, no subchondral collapse, sorry. Steroids are poor results if they're the cause, and you have to use meticulous technique. You have to choose your patient well. The head should not have been collapsed. It should be still well maintained, well congruent, and you do your core decompression directly in relation to the zone of the osteonecrosis, and you remove the pressure, and then you can impact it with autograft. Vascularized fibula strut for healing and support has been used. Particulate bone grafting, a necrotic segment adjacent to strut has also been, and the core strut stimulates osteogenesis. This is the technique being used. After collapse, the total hip arthroplasty remains the mainstay in the treatment of osteonecrosis and results. Total hip arthroplasty provides reliable treatment of symptoms and has been shown with up to 98% survival at 10 years. Other arthroplasty options include hemiarthroplasty, hemi-resurfacing, and total resurfacing. But nowadays, resurfacing is losing popularity because of complications, because of metal granulomas, causing wear debris and reactions. Also in pregnant women, you should not use it because it passes through the placenta. Compared with other historical series. However, this has yet to be substantiated in the literature. This is now we're coming to arthritis of the hip. Arthritis is the most common cause of adult disability in the United States. In 2005, more than 20% of adults self-reported the condition as physician diagnosed. In 2009, arthritis was the fourth leading cause of hospitalization in the United States. This is more commonly seen in women and less frequently in people of Hispanic origin. Joint pain led to activity limitations in more than 40% of the patients with physician-diagnosed arthritis, a figure expected to increase substantially by 2030. The cost of arthritis-related care in 2003 totaled $128 billion. The workup. Patients with arthritis of the hip commonly present with activity-related pain centered in their groin and buttock that is insidious in onset. They will often note difficulty walking long distances, donning and doffing footwear, and getting into and out of the vehicles makes it difficult. They need support. Patients also may present with a chief report of knee pain, which is referred via a branch of the obturator nerve. In the light of origin of pain and a clinic with knee pain must undergo a radiographic examination of the ipsilateral hip. Patients may have pain over the greater trochanter and may walk with a limp. A limb length discrepancy may be noted, particular cartilage, and hibernation of the subchondral bone, and may lead to limb shortening of the affected side. Patients with long-standing arthritis will usually have an external rotation contracture with painful and limited internal rotation on physical examination. Radiologic evaluation of the hip is of paramount importance. Both AP and lateral views of the affected side should be obtained with an AP view of the pelvis. Additional views of the entire femur or full-length standing views also may be helpful if other deformities warrant their procurement. Radiographic evaluation of the hip is of paramount importance, and both AP and lateral views of the affected side should be obtained with an AP view of the pelvis. Additional views of the entire femur. Lateral AP to make sure that there's no other deformities that may hinder the management, whether surgically or anything else. Radiographic evaluation of the hip is of paramount importance. Okay? So keep this in mind. دي ما بتغير هيدي. Okay, so these are the views that we like to take. We like to take in AP a lateral view. The classic radiographic signs of coxarthrosis include joint space narrowing, osteophyte formation, subchondral sclerosis, cystic changes, which are collectively included in the classification schema of tonus. And this is the tonus classification. You have to know this classification. You have to know of how severe is grade 3 with the large cysts in the head or acetabulum and severe joint space narrowing. So please remember the tonus classification. Remember in osteonecrosis, remember in DDH, the Crow classification, and the Greek fellow, Hergenstjold, I don't know what, treatment algorithm is the history, the physical examination, and radiographic images support a diagnosis of coxarthrosis, non-surgical and surgical treatment algorithms consisting of weight loss, activity modification, anti-inflammatory medications, gentle hip abductor strengthening exercises should be used. If these modalities fail, or a patient believes his or her quality of life remains impaired, surgical intervention may be considered after a detailed discussion regarding the expectations and activity demands. Temporizing intra-articular injections of the hip should be avoided because the beneficial effect is less predictable and usually shorter-lived compared with that of the knee. An intra-articular steroid injection also may place a patient at increased risk for a periprosthetic infection if performed within 2 months of the definitive arthroplasty procedure. Just to know, many times during the exam, one of the treatments in the past was that we used to do a fusion of the hip, which now we avoid doing. But if you asked at what angle should you fuse the hip, you should mention 30 degrees flexion, 0 to 5 degrees external rotation, and 0 to 10 degrees adduction. I repeat, 30 degrees flexion, 0 to rotation, and 0 to 10 degrees adduction. Now we're coming to the interesting part. Primary total hip arthroplasty, which I will be terminating this lecture following this. Are there any questions? I want to take 2 minutes break only so that I can drink and rest my voice. بس إن شاء الله ما نكون عم نزهقكم. بس this topic خالد عم زهقكم؟
لا دكتور جون، لا والله احنا
Look at, I'm giving you certain points. الواحد ما بينتبه لهم. لو بيفتحوا عينيهم بيعرفوا عم بعطيهم the points that I've learned from experience and they were dangerous.
صحيح.
You have to learn from your experience. What you do and what you should not do.
Yes. Okay. Okay. Thank you.
بس يا خالد ماني شايف كثير ناس اليوم.
اليوم لا بالرويكيان. ها قصدك الحضور اللي على هذا؟ لا احنا مجتمعين بالصالة.
خفت ما اليوم يكون
ايوه يعني
يكون فزعانين من نهار الجمعة و13 الشهر.
هو تعرف اللي مشاركين عبر البارتيسيبيشن يعني بالزوم ايوه قليلين، لكن اللي حاضرين معنا كثير. ايوه
خالد بترجيك بتشدد على الشباب بلا ما يقروا هاللكشرز مش رح بينفعون. إذا بيقروا بينفعون. ما بدي اتعذب واعطيهم لكشرز وما يقروا. عم تفهم خالد؟
عارف شوف معظمهم هم بيقروها
يقروا على كل توبيك.
اكيد
الحقيقه
هلا
جمعت جاي رح بعطيهم اللي essentials تبع السباين يلي لازم يعرفوها، لان احنا بنطلب من الناس يعرفوا سباين. انا بعرف انه سباين ده ضعيفه وين ما كان. انا بنصحكم انه تقعدوا تقروا chapters عن السباين. جيبوا كتاب concise book like Secrets of Orthopedics.
ايوه
فوتوا على السكشن تبع سباين اقروها. شو بتخسروا يا شباب؟
خلاص هم عم يسمعوك، وهذه محاضرة الاسبوع الجاي.
عم بيسمعوني ايه؟
ايوه
اوكي يلا رح كمل بالبرايمري. هلا this includes the essentials what you should know about total hip. Now you have to aim at, when you're doing a total hip, you have to think of having a proper fixation. The articular process that you're using has to have a proper wear profile, and you have to think of stability. If these three don't come together, the total hip won't last. Now, there are several types of total hip. One is the ingross on pore surfaces. In this case, you should aim for ingross at the proper sized pores, at the proper depths, and avoid motion. It should be a press fit, and this I will be discussing in detail. In cemented total hips, I would like to stress they don't last long. The 5-year survival is 12%. The 10-year survival is 33%. In the 16-year-old, it's 67%. And in the 16-year-old, we know that the revision rate is 82%. It's a non-biologic technique. You get the patient, you put a cemented total hip, and the patient is young. The revision rate is very high because it's not biologic. And if you get cracking, I will tell you this. Keep this in rule number 1. So, when you have a young active patient and you insert a cemented total hip and you use metal on polyethylene bearings, what is the problem? Why do we have a problem? The patient is young. We have more size. We have weak cement. So the cycles times stress all lead to wear. فما تنسوا اياها. الصغار اذا بدكم تستمن اجمالا ما بيضاين if you have more cycles and there is more stress or very high stress on the prosthesis. Cement fixation. You have a mechanical fixation. اوعى تفكروا انه لما تحطوا سمنت عم تزقوا البروسيس العضل. لا، هيدي مش مظبوطه. Candidates fail on this question. Cement holds the prosthesis in by means of a microlock. This is the reason why we like irrigate. We like to use a pulse irrigation and suction. We like to use, at times people use some form of constriction of the vessels to prevent bleeding so that the trabecular space are empty. Cement undergoes fatigue and it can lead to microfractures. If it fractures, there is no. And one additional interface. Cement fixation failure, cemented cups fail at a higher rate. And this is a question I love to ask. Why do cups fail when we use cement and stems don't fail when we use cement very quickly? Why? Because if you look at the acetabulum is continuously under a certain shearing force. Being that there are tension and shearing forces, this lets the cup fail. While the stem, the forces on the stem are compression. Please keep this in mind. Now, what about bone ingrowth? In contrast, bone ingrowth is a dynamic, it's a biologic fixation. Why? Because we're depending on bone to grow within the trabeculae, to grow in the pores which are present in the stem or the cup. And the size of the pores is important. We like pores to be between the size of 50 and 150 microns. That's it. Be life lasting. Depending on the amount of motion, implant fixation occurs. Via bone ingrowth, if there's too much more motion, it becomes a fibrous ingrowth. And if severe, it's a fibrous encapsulation. The formula success requires an optimal pore size, an optimal pore depth, an optimal porosity, minimal gaps, rigid fixation, minimal implant micromotion, cortical contact, and normal bone metabolism. This shows you the normal pore size. There have been varieties between 175 and 350 or 50 to 400, but we've chosen between 450 and 150. This is the proper size, and we like the bone to grow within it, not be fibrous, not be encapsulated, etc., to an improper press fit. The pore depths, the deeper you go, the better it gets. Greater pore depths provides stronger fixation. This is a slide which shows you that the more you have a pore depth, then the better the fixation. Porosity, surface area available for fixation, If two porous coating will share all, we like to have 40 to 50% coverage, not more. And the more area for bone to grow into, maximum porosity should be around 55%. Otherwise, it would share or use this size, this amount. The gaps between the prosthesis and bone should not be more than 50. It should be less than 50. Why? Because if you don't have this contact or a closer area, bone won't ingrow. So you have to minimize micromotion. There are two techniques in which we use fixation either of a cup or stem. One is a press fit, and the other is line-to-line technique. The press fit is a technique, it's not a fixation method. You should ream the canal to size, insert the stem slight in size, or ream the cup to size, insert the cup in one size, and then you impact it. But you have to be very careful, because if you're not careful, you can have a fracture of either the acetabulum or stem. But once you get the press fit as well, because the acetabulum will be impacting on the cup. You have to be aware of this in the osteoporotic patient. You have to be aware of this if you do over-ream that component will go into the pelvis. This shows you a press fit, what it's like. This, let's say it's the femoral stem, and you're rasping to go into it, and then you press it. You press it. It is larger than the area in which it's going. So you have a compression of stress, and this gives you fixation. So provide the initial stability, long-term fixation provided by biologic and micro interdigitation. It grows. As I mentioned, you could have a fracture because of under-reaming, and the main reason for acetabular fracture and total hip is under-reaming. Initial rigid fixation, hip stem insertion, and line-to-line. The other type is line-to-line. The type that I discussed of fixation is a press fit. The line-to-line is a technique. You ream the canal to the size, and you insert the stem of the same diameter. Extensive porous coating provides initial interference fit, long-term fixation, and it's a biologic fixation, but you have to use screws to assist in the fixation to become solid. No screws. Line-to-line cup technique requires and on screws. What about cancellous bone? Is it not weight-bearing? No, it's not. The stem must rest against the cortex. When you're rasping the medullary canal, you should make sure that you have reached to prevent settling down of the stem. So, shear and torsional strength. Stronger when implant is adjacent to cortical bone as opposed to cancellous bone. This shows you a stem that is being inserted on the left side and you have cancellous bone. This will settle down, especially if you don't have a collar. While on the right-hand side, you see that stem is larger, there was more rasping, and it's resting on the cortex. It won't settle down. Bone ingrowth. To have bone ingrowth, you have to have cortical contact. The gaps between the cortex and the stem should be less than 50 microns. The pores should be 50 to 150 microns. And porosity should not be more than 50%. It's a threshold. The line right over here is the lower level of porosity. And motion should be less than 50 microns. Now, the last metal surface with a grit material, it creates micro-divots and bone grows into the divots. This is it. This is an on-lay grit blast. It's not within bone. So the fixation is superficial and it can pull out with time. It has some valleys similar in size to the opening seen in porous coated surface. This is how it is. Bone will grow on this and hold, but this, don't forget, is attached. This can shear away. When you have pores, it's different. Grit blasted, linear correlation between implant surface and push-out strands. 10 surfaces tested with it, so it's not as strong as the porous. Much more dependent on stem geometry, usually double wedge tapered design. You need a very tight press fit. Great areas needs to be in extensile. We have to impact it in strongly. The drawback, bone on growth, not ingrowth. Fixation only on the surface. And over here, I have to take this out. And stem setting, if pore press fit, settling, not setting, but settling. Yani, it won't hold well. Stem design technique is very important to success, not as forgiving. Will the coating cause stress shielding, proximally ingrid blasted? We don't know. You have to keep this in mind. And surface coating, such as hydroxyapatite, you cannot use it as a form of fixation. Nowadays, we're using hydroxyapatite on pores. It encourages, and this is very coated stems, the connection or the attachment of hydroxyapatite to the stem is weak and it can shear off with time. Successful application requires high crystallinity. High crystallinity, low amorphous areas will dissolve. So you have to pay attention. The caveat, hydroxyapatite alone may delaminate long-term. Hydroxyapatite on porous coating is a safer choice. This is what I'm telling you. Uncemented total hips, the multiple permutations, extent of coating, proximal coating is what we do because it scratches, never the head. Nowadays we use a lot of cobalt chromium. And the gold standard for total hip is a hybrid total hip, uncemented porous coated, hemisphere acetabulum, and cemented femoral stem. This is a choice whether to use it or not. In Europe, they love using cemented femoral stems, but in the States, they prefer uncemented. So, at this time, cemented femoral component using modern cementing techniques paired with porous coated acetabular component can give coating, and the load is transferred from the lower end of the pore in the metaphysia downward. If you use fully coated, then it has to change. It will go at a lower level. We don't like to use extensive porous. We don't like to have spot wheels, because this weakens and creates stress rises. So keep this in mind. This is a spot wheel, and this would create stress rises, especially in these cone-shaped stems, which are not pointed. This is a spot wheel. Okay. I want to go more quick because I'm quite late. In porous coating, when you use extensive porous coating, then what will happen is that due to stress shielding, you will get loss of bone proximally. You have to keep this in mind. I want to mention something also. I have been very long and I can hardly talk, but I want to mention, if you get a stem like this, don't show it to your friends. This is a very bad stem. You have to aim at centralizing your prosthesis, because this will create a zone of stress. Distal fixation, distal pores, you'll create a cantilever effect and you can get breakage of the stem. فما تروح على الشركة وتجد stem غلط. This is not true. When you have porous coating, what happens is that stem fixes distally. Of surgery. You have to keep in mind that as you're doing a prosthesis, you have to keep in mind that if you go through a posterior approach and using a retractor, don't forget that you have the sciatic and you can damage the sciatic nerve. Don't forget if you're working underneath the gluteus maximus, you have the circumflex femoral artery. You have to pay attention to it, the medial circumflex femoral artery. If you're working at the lower end of the acetabulum, you have to think of the obturator vessels and all these position crucial. Now, you should also consider individual cases. In sickle cell disease, you have early loosen. Psoriatic arthritis, you have higher incidence of infection. Ankylosing spondylitis, you have heterotopic ossification, where you can give radiation or endomycin. Be careful of these points. Osteolysis is a problem, and you can get wear debris coming from polyethylene, from metal, from ceramics, and create a reaction. You have macrophages coming. They release interleukins, 1, 6, prostaglandins, tumor necrosis factor, and these, together with acid phosphatase, they destroy bone. But inshallah ma تكون. Do you want me to stop?
So, Jone,
Right. Osteolysis represents a histiocytic response to wear debris, and its steps in the process include particulate debris formation, macrophage activity, activated osteolysis, prosthesis micromotion, and particulate debris lead to osteolysis and failure of the stem. Okay, so we have several types of wear. You have to know the difference between abrasive, adhesive, and linear wears and volumetric wears. The most important is the adhesive wears. These debris come to the pores, they attach to the pores, they start causing osteolysis. These adhesive particles are pulled out of the pores with motion, and further damage is caused. And also you have third-party body particles. Be very careful of this. You have to know about the types of wear debris. I repeat, adhesive, linear wear, volumetric wear, and third body wears. And you have to read about them. These show you the adhesive wear. And this is the major cause of osteolysis. You have phagocytosis, submicron, particles, and this polyethylene release of the particles. Even though you have ultra high molecular weight polyethylene, even if you have a high cross-linking of the polyethylene, you still have wear debris. Okay, so these are the products that are released that cause osteolysis. Interleukin-1, tumor necrosis factor alpha, prostaglandins, oxide radicals, hydrogen peroxide, and acid phosphatase is the most. It causes lysis mostly. Okay, so you have to pay attention to this, and you should know that the wear debris occurs in the acetabulum from the polyethylene. Wear chooses under pressure with motion to move distally, and in this way it surrounds the stem. This shows it how. Area of wear debris starts behind the cup, it goes around the screws, around the stem as it moves distally, and around you have to know this. Particulate debris formation, the types of wear. Adhesive is the most important in osteolytic process. Pay attention. If you ask this in a question, it is the most important. Microscopically, polyethylene sticks to the prosthesis and the debris gets pulled off. Taping off particles due to gait. The third body wear, particles in the joints cause abrasion and wear. Volumetric wear, main determinant of number of particles created, directly related to the square of radius of the head. Volumetric wear is more or less creates a cylinder. Okay, head size is the most important factor in predicting particles generated. Linear wear is measured by the distance of the prosthesis has penetrated into the liner. Highly cross-linked, ultra-high molecular weight, polyethylene, you have to know about it. It generates smaller wear particles. You have to pay attention of how it's sterilized. You don't sterilize it in air. You have to be very careful if you ask that question. The factors increasing the wear in total hip. If you use a cup with polyethylene less than 6 millimeters, this would wear. Malalignment of the component position. Patients less than 50 years old have a higher incidence. Men have a higher incidence because walk more, they're more. Femoral head size between 22 and 46 millimeters in diameter does not influence wear rates. So please pay attention to this, okay? Macrophage activation. The macrophages are activated. They have an osteolytic function. You have tumor necrosis factor, osteoclast activating factor, oxide radicals, hydrogen peroxide, acid phosphatase, interleukin 1 and 6. Remember these, prostaglandins, all these are involved in osteolysis. And you have to know how the debris disseminates. And I will have to skip some areas. This shows you the linear and the volumetric wear. You have to know also about the types of, I would like you to know about surgical approaches we spoke about. I want you to know of the generations of cement. There are 3 generations. You have to know them. What's the difference between the first and the third generation? This is very important. That's me. Another point, if you have a patient and you do a cemented hip, cemented stem, and if you get the same patient and you do a cementless stem, which one is more predisposed to death? You should say the cemented. Why? Because it creates, through the pressure of cement, pressurization, the cement will cause emboli, and the patient could have a sudden death. Manu, some say it's anaphylactic shock. No. So these are points you have to know. I'm trying to see. Hip resurfacing is out, except in England. You have to pay attention to this. Okay? You have to know these points. You have to know about the acetabulum components, the modular, the bearing surfaces, polyethylene, metal, ceramic. What is the difference? When would you use this? And you have to know certain points. I want to mention also, let me see, of how the polyethylene is prepared. This is a lecture I usually give, and this lecture is how to prepare highly cross-linked polyethylene and how to sterilize it. All you need to know is don't sterilize. Also heat to get rid of the free radicals. We do it on 2 occasions. Steroids should not be added to polyethylene because it weakens it. So you have to pay attention to this. You have to know this. Making a recording of this lecture, memorize them from my lecture. Okay? So don't forget these. This is how to sterilize the polyethylene. Okay? So these are points you should know. Okay?
Okay.
And that's it. I cannot give more than this. I cannot speak anymore. Okay?
Okay. We will
Like
record the lecture.
Khalid, was I clear today?
Yeah, very clear. And most of the last year, 4 year and 5th year get advantage. Some of them in the first years.
They appreciated or didn't?
Yeah, they appreciate.
They appreciate.
Sure.
ليك أنا يا ريت
مشيها دكتور
ليك
جون، مشي المحاضرة عشان نكملها.
شو
نعم مسجلها.
بدهم ياني
محاضرة مش
كملها؟
مشيها؟ ايوه
بدهم ياني
مشي السلايدات
كمل؟
بس. مشيها يعني بس عشان نسجلها فقط.
طيب يلا رح بحكيها.
طيب.
First of all, let's take each one alone. Let's take surfaces of metal to metal. We don't like using metal to metal because actually the wear debris from metal has given granulomas and cysts and early osteolysis. So we quit using metal to metal. For this reason, we don't use resurfacing alone as a cause. Yani resurfacing, we don't like to use it. The reason why, when we do resurfacing, there is a weakness between the resurfacing of the head with respect to the neck. And this creates a weak point, and we get many fractures at this site. I suffered from many of my patients after 2 to 3 years to 4 years coming to me with a fracture at the junction of the head resurfacing with respect to the neck. So this is a point from resurfacing. Now, if we use ceramic on ceramic, ceramic is excellent. It is a hard surface area. The wear debris is much less than others, but they're finer. But the problem with ceramic is that if it breaks, it's a problem. We like to use ceramic on polyethylene. This is something that they should know. Now, I would like to mention one point, is that using ceramic in young individuals and saying that this is good. The problem is there's much argument. They say, once you use a ceramic and you had complications, you have to reuse a ceramic prosthesis because the wear debris that arises from ceramic is quite high. So you have to pay attention to this. So ceramic on ceramic, metal on metal, polyethylene, ultra high molecular polyethylene is used in the knees, but the cross-link is used in the hip. The cross-linking gives a better covalent fix, and with heat, you can get rid of the free radicals. You can use gamma radiation to sterilize it, but in oxides, not in air. It's a disaster. هلا في شغله انا بدي اقول لكم اياها. انتم بالمستشفيات اذا بيجيبوا لكم البروتون على الشلف they degenerate, they break, they pour. ونحن لاحظنا بهال components يلي كبار يلي انجأ نستعملهم كنا نجيبهم نحطهم على الشلف. حتى البوليإثيلين كمان معهم بتلاقي البوليethylene fragments after without being used. You have to pay attention to this. That's why we like to sterilize polyethylene not in the air. It's bad. Let me see if there's something else I would like to mention. Hard on hard, we mentioned this. Debris is more. Another thing about ceramic. Ceramic is known. I have seen quite a few patients coming to me with squeaking, and they're not painful, but malposition of the components prevent squeaking from occurring. Don't forget, metal pseudotumors and aseptic lymphocyte vasculitis, that's what we call alvals. Now, I would like to mention is that there has been much argument about patients with metal on metal, whether it will cause cancer or not. This has not yet been proven fully, so you have to keep this in mind. Another metal on metal wear debris, we said it crosses the placenta. Don't forget that we don't like to use it in young women who are during, they can give children. So this is a point. Deep vein thromboprophylaxis, you have to know. Total hip arthroplasty can fail for a variety of reasons, and understanding the cause of failure is of primary importance so that the failure can be addressed with the appropriate revision strategies. Common modes of failure. Why? They get infection, there's loosening, there's instability due to improper fitting of the prosthesis, and you have a periprosthetic fracture. Patients presenting with a history of painful hip arthroplasty should undergo a thorough history and physical examination. The key signs to elucidate from history include absence of pain relief following the initial procedure. Keep this in mind. Prolonged wound healing. The need for antibiotics. This you get out from a proper history. Procedures related to wound problems. A history of prolonged limitations of weight-bearing status. A history of dislocations, mechanical symptoms of locking or catching and squeaking also should be ascertained. An understanding of comorbid conditions or habits that might lead to perioperative complications such as smoking, diabetes, steroid use, or coagulopathy should be gathered. Physical examination should document gait, length discrepancies, abductor strength, range of motion, and any localized tenderness or masses. The skin should be closely examined for evidence of sinus tracts. Don't look at the patient just like that. Undress your patient. Examine him thoroughly. Look at the wounds, see is it healing or not, or see if the patient has venous stasis. Pay attention to these points. Radiographs should be scrutinized. Mechanical failure, periprosthetic fractures, and available bone stock. The component interface should be critically evaluated for signs of loosening. Component migration also should be investigated if serial radiographs are available. Dedicated Jode views should be obtained if pelvic discontinuity is suspected. CT may help in determining the extent of bone loss or osteolysis in the revision setting. Baseline laboratory studies, including a CBC with differential, is very important. ESR and C-reactive protein should be obtained. If inflammatory markers are elevated, of the hip under ultrasound or fluoroscopic guidance is warranted and should be obtained. Nucleated cell counts higher than 1,700 or a neutrophil percentage exceeding 65% is strongly suggestive of a periprosthetic infection. Now we come to periprosthetic infections. I'm going to go through it. The discovery. A periprosthetic infection can be treated with an irrigation, debridement, liner exchange, single-stage revision, or two-stage resection and reimplantation following a course of intravenous antibiotics. The type of treatment is usually dictated by the timing of presentation in relation to the onset of symptoms and the causative organism. Acute infections, I repeat, acute infections may respond to an irrigation and debridement and bearing exchange. Chronic infections are generally treated with a staged approach in North America with mid to long-term survivorship free from reinfection in as many as 93% of cases. This study also highlighted the importance of achieving stable component fixation. Mechanical failure rates were noted to be higher than those of reinfection. Another study noted a recurrence of infection in 26% of patients after two-stage approach and the risk factors for failure, a poor host and resistant organisms. Instability. Recurrent instability has been established as the most common reason for revision hip arthroplasty. Instability following total hip arthroplasty may result from malpositioned components, sequelae of infection, and poor abductor tension. The cause of instability should be determined because it will dictate treatment. Acetabular components should be placed in approximately 40 to 45 degrees of abduction and 50 to 20 degrees of antiversion. However, the conversion of antiversion of those components must be considered to optimize hip stability. These requirements may be altered if abnormal pelvic tilt and incidence is encountered, as is seen in patients who have undergone lumbar and lumbosacral fusion. Let me tell you, if you're doing a total hip following a lumbar fusion or scoliosis, you have to do a proper pelvimetry to put your acetabular component in the proper alignment so as to prevent a dislocation. Weakened abductors that have been damaged iatrogenically during multiple approaches to the hip with poor soft tissue management, or in instances of greater trochanteric fractures, should be identified, and the need for trochanteric advancement or abductor reconstruction assessed. In cases in which abductor function cannot be restored, constrained liners provide an alternative means to achieve hip stability. If constrained liners are used, the surgeon must be aware of the additional strain placed on bone component interface and should augment cup fixation with additional screws. Components that employ dual mobility design. These components, which have been used in Europe for 2 decades, pair a large polyethylene head with a cobalt chromium liner. A smaller head is snap fit within the polyethylene head. This dual mobility I have used in so far around 75 cases of mine. I am very pleased with the result. It gives us stability. And one thing, it lets you sleep at night. So you have to keep this in mind. I like the dual mobility. It's a good process. This construct creates a larger articulating surface, providing for an improved head-to-neck ratio, and most importantly is a greater jump distance. The jump distance is the amount of flexion before the head reaches its limitation. The larger the head, the more stable. The results of dual mobility components used in the setting of recurrent instability was reviewed by investigators who noted that in 3 European studies with between 4 and 8 years of future dislocation was prevented in 95 to 98% of the patients. You have to keep this in mind. An additional advantage of dual mobility concept is that theoretically it places less force on the acetabular component than aseptic loosening and osteolysis. Researchers have extensively classified bone loss encountered in acetabulum and the femur during revision total hip. Acetabular defects can be more broadly characterized as constrained, segmental, or involving a pelvic discontinuity. Contained defects usually can be successfully managed with impaction of cancellous allograft or a bone substitute and large hemisphere cups. Segmental defects can be successfully surface in contact with at least 50% of surface contact with the bone is achieved. So you can use tricortical crest graft or bulk allografts can be fixed with screws to maintain a remaining acetabulum and reamed if insufficient contact and implant instability is noted. Pelvic discontinuity can be managed through a variety of techniques. Stable distraction can be accomplished by using a large acetabular component. The affected column can be plated before acetabulum cup cage constructs or a custom tri-flange component can be used. The technique used depends on relative stability of the pelvis, the size of the associated bone defect, is a preoperative oblique and lateral view of a total hip with failed osteolysis and aseptic loosening with eventual cup migration and dislocation. Intraoperative photographs demonstrate the cup cage construct that was used to achieve stable fixation of the revision acetabular component. shown in the post-operative radiograph. Femoral bone loss assessment should focus on the portion of bone that remains relatively intact because they refine revision fixation option. In most cases, the metaphysis has been violated and will not impart reliable stability to a revision implant. Consequently, extensively coated cylindrical stems and modular tapered stems are preferentially used because they achieve their fixation and diaphysis. In a recent study comparing these two stems designs in the revision setting, the modular tapered stems were associated with better outcome scores, fewer intraoperative fractures, and restored femoral anatomy more accurately than cylindrical stems. So this is it. I would like to mention about preoperative fractures. We all know that we're using the Vancouver classification, and in A you have the trochanter, greater or lesser trochanter, and B and B1 and B2. You have to pay attention that you can have a fracture along the stem, and the prosthesis let me mention this, like fractures within the associated loose stem. B3. B1, it's well fixed, and you can apply a plate. B2 and B3, you need to change the prosthesis as a whole. Some say that even in B1, if you change the prosthesis, it will be better. And of course, in C, it's just like any other fracture that we deal. So you have A, B, 1, 2, and 3, and then you have C. So remember, it's not difficult to remember these types of fractures. So that's what you have to know also the areas of osteolysis. You have to know the groin zones and the Delis zones. The Delis zone groin is 7 zones, and it starts first in the greater trochanter and moves around. So you have to know this. Okay, and you have to know about the Paprosky type 1 fractures, of what you should do, type 2A fractures. All these are important for you to know that you have learned over the years. I cannot go through them. You have to go through them. I'm giving you this lecture. Actually, this is a one full book. So please take this lecture from Dr. Khalid and study it from cover to cover. And this is it. I just cannot carry on anymore. And I'm really tired. 3 hours, one stretch is really killing me. Okay? So let me see if there's anything more we have to know. Actually, we have repeated some of the talks many times, especially on the metal on metal. And I would like to conclude, patients younger than 35 years with round femoral heads and intact articular cartilage demonstrated on MRI or plain radiograph, Tonus grade 0-1, are the best candidates for non-arthroplasty treatment of acetabular dysplasia in the form of Viennese periacetabular osteotomy. Total hip arthroplasty provides reliable improvement of symptoms and has been shown to be associated with up to 98% survival at 10 years in this setting of osteonecrosis. Recurrent instability has been established as the most common reason for revision of hip arthroplasty. Painful metal hips should undergo soft tissue imaging with either ultrasound or MRI scan to evaluate for the presence of pseudotumors. In the absence of a pseudotumor, revision can proceed on an elective basis. A soft tissue mass mandates more urgent surgical intervention secondary to risk of soft tissue envelope, which compromises future implant stability and overall function. Thank you. شو وين صرنا؟
شكرا دكتور جون.
خالد.
ايوه.
بعتقد بدي عملية للصوتي.
الله يعطيك العافية.
يعني بقول لك الحقيقة تعبت. يقروا بعجل.
يوري فورت يا باشا على ما تقدمه وما تبذله من أجل الله يحفظك.
شو بدك سؤال؟
يعني احنا بنجمع لهم المحاضرة يقروها ويراجعوها وبنعطيهم أسئلة عليها يعني بعدين إن شاء الله.
أعطيهم إياها هيدي يدرسوها. أيوة. يدرسوا كل سكشن لحالها. هيدي صدقني
هي فيها الخلاصة لكل شيء.
ما في شيء تركته برا، بس they have to
أيوة.
read it. They have to. ليك لازم يعرف شو types of wear debris. هيدي مهمة بنسأل كثير عنها. يعني which is the most important. It is the adhesive debris. لازم يعرفوها هيدي. لازم يعرفوا بالمثل أو مثل. No evidence that it causes cancer, but we know it passes the placenta. بالceramic لازم يعرفوا side effects, when to use it, how, what about the etc. يعني اشياء very common. يعني اكثر من هيك رح بقول لك. اوكي خالد، يلا نسمع من جماعة الجاية spine. رح بعطيهم الهايلايتس of the spine.
اوكي
يلا.
شكرا لك. اوقاتك طيبة.
باي باي.
يا جماعة